Hello and welcome. I'm Heather Cronus-Danek, Senior Director of Development for Individual Giving for the Eye and Ear Foundation. The Eye and Ear Foundation is the fundraising entity for the departments of ophthalmology and otolaryngology at the University of Pittsburgh School of Medicine. Everything that we do supports research and clinical transitional programming. Today's Sight and Sound Bites which is our bi-weekly webinar series, is on ocular inflammation. We have two wonderful speakers today. Dr. Marie-Hélène Errera, MD, PharmD, PhD. She is an Associate Professor of Ophthalmology. Dr. Errera specializes in comprehensive ophthalmology and retina and vitreous diseases. She completed her fellowship at the Sorbonne in Paris and at Moorfields Eye Hospital. And she received a medical degree at the University Medicine Bichat. Her research interests include ocular inflammation and the epidemiology of uveitis. Additionally, we have Dr. Alex Mammen, Clinical Assistant Professor of Ophthalmology, Medical Director of the Charles T. Campbell Microbiology Laboratory, Director of Cornea, External Disease, and Refractive Surgery Fellowship. Dr. Mammen specializes in cornea and external diseases, cataract and refractive diseases, and comprehensive ophthalmology. He is on the Cornea, Cataract, and External Disease Services and the Refractive Surgery Service. Dr. Mammen is certified in ophthalmology by the American Board of Ophthalmology. A few housekeeping tips before Dr. Mammen kicks all this off. Chat has been disabled, but please ask questions. Please ask them in the Q&A box. Any personal medical questions we will not answer during the Q&A at the end, but we'll send, if we can, answers back to you. So with that being said, Dr. Mammen.
Thank you. So, as has been mentioned already, I focus on the cornea and the surrounding area. So we'll start by talking about that and the inflammation affecting those areas. So we'll start with the eyelids, which protect the ocular surface. And if we're looking at inflammation, we can touch on contact dermatoblepharitis. So blepharitis referring to inflammation. So itis referring to inflammation, bleph referring to the eyelids, and dermato referring to the skin in general. So the skin around the eyes is what we're talking about here. So the patient can present with itching, redness, swelling, watering of the eyes, and a mucoid kind of drainage to the eyes. So what are some causes? This is something that we see not infrequently associated with use of certain medications that are listed there, whether it's for dilating the eyes like atropine or homatropine, antibiotics like aminoglycosides like neomycin, gentamicin, tobramycin, or antiviral agents like idoxyuridine, which is really not used anymore, and trifluridine, which is used not uncommonly. The brand name is Viroptic. It's used for viral infections, specifically herpes simplex infections of the cornea. And glaucoma medications like alpha adrenergic agents like brimonidine, most commonly, as well as beta blockers like timolol, less commonly. So preservatives are a big factor in causing allergic reactions like this. Marisol, which is not used anymore, was very toxic to the ocular surface. Benzalkonium is used very commonly in a lot of topical drops, and EDTA is also used. So benzalkonium, most common cause of reactions in patients who have them. So cosmetics, as you might expect, anything that you apply to the eyelids and surrounding areas can cause in inflammation or an allergic reaction. Environmental substances, exposure to a variety of environmental agents, can also stimulate this sort of response by the body. So it can be immediate, either minutes after exposure or delayed days to months after exposure. Treatment is, of course, to remove what's causing the inflammation. Antihistamines and mast cell stabilizers are useful to help with the allergic response that's mounted by the body. And then sometimes that's not enough. Depending on the severity, you might need to add topical or oral steroids, or if even more severe, immune suppressing medication for chronic, more severe conditions. Atopic dermatitis. This is chronic condition, genetically susceptible individuals with a personal or family history of allergy or asthma or aspirin hypersensitivity. So the body's immune system is just not as finely tuned, and it reacts to what is otherwise normal exposure to things in the environment. So this is a picture showing around the eyes, dry, red, itchy skin, flaky skin, scaliness of that skin. And you can also have it in the rest of the body. And you've heard of eczema. So this is just eczema around the eyes. So causes a lot of itching, and then you get the sequelae of the itching, so the scarring that can occur from chronic itching. Delayed hypersensitivity reaction. So though it's exposure to different factors and the body's response to those factors. So it mounts a delayed hypersensitivity reaction to these allergens. And there's a impaired cell-mediated immunity. So these are the B cells and T cells of the immune system. There's an dysfunction of this type of immunity in the body. There's increased allergy response. So like a hyperactive allergic response, you can think of it like that. So there's increased production of these immunoglobulins, immunoglobulin E, which is associated with allergy. And there's, because of that increase in immunoglobulin E production, there's more release of these factors from the cells, or specific cells that are associated with allergy and the allergic response. Histamine is released from these mast cells and basophils. And so that's what causes all the signs that you saw previously mentioned. So the treatment is allergen avoidance. For mild cases, moisturizers can be useful, but even for more severe cases, once we've calmed down the inflammation, moisturizers to keep the surface intact. Topical and oral steroids are important, as well as topical and oral immunomodulatory treatment. The steroids are just for acute short-term use, and then you may use the immunomodulators for long-term suppression of the immune system's overreaction. So moving on to the next surface, or the conjunctiva. This is that skin on the white of the eye. Over the white, which is called the sclera. So this is ballooned up in the picture you see in conjunctivitis, or inflammation of the conjunctiva. So most common being allergic conjunctivitis, seasonal or perennial. So with spring and fall, with seasonal or perennial, year-round, both eyes are involved. Itchy, watery drainage. Here you can see on the inside of the eyelid little bumps called papillae. Seasonal can be caused by common allergens that we are all aware of. Perennial, as well, from the dust mites, animal dander chemicals, adhesives, latex, a variety of different antigens. So the treatment for supportive treatment, or just to soothe the area, cold compresses, preservative-free artificial tears. Topical treatment, so that's the drops, antihistamines, mast cell stabilizers, a list is shown there to the right. Non-steroidal anti-inflammatories are useful, but need to be used with care because overuse can predispose to breakdown of the corneal surface and corneal perforation. And then topical steroids. So we try to use the least amount of steroid needed to calm down the inflammation. So systemically, depending on the severity, you can use oral antihistamines. You can also do allergy shots or desensitizing injections. So more severe versions of this. So this is mild being the allergic conjunctivitis, vernal keratoconjunctivitis, seasonally recurring bilateral inflammation of the cornea and the conjunctiva, the cornea being that clear part in the front. Occurs predominantly in children and young adults, especially in male, twice as common. So you see these big papillae on the inside of the eyelid, like big cobblestones. You can have inflammation at the edge of the cornea called the limbus. You can have these ulcers that form because of the chronic inflammation of the inside of the eyelid. So treatment for this also is a similar steroids, antihistamines, lubricants, but because it's more severe, you're more likely to need higher level of treatment with steroids and including topical and sometimes even oral steroids just to calm things down. So in adults, you can have a similar sort of presentation with atopic keratoconjunctivitis. We talked about atopic dermatitis around the eyelids. So this is on the conjunctiva. This is with a similar process of delayed hypersensitivity reaction and impaired cell-mediated immunity. So you have just chronic brewing allergic reactions, and it can cause scarring and blood vessels to grow onto the cornea. So if we look at how this might manifest in vernal on the left column, atopic on the right. So vernal refers to the spring and summer. Younger patients, you can have eyelid swelling, lots of drainage, giant papillae, these areas of swelling on the limbus, the ulcers. Usually doesn't go into the eye and affect structures like the lens. Whereas atopic year-round adults, you have thickening of the eyelids, watery drainage. You have smaller papillae or little bumps. You can have blood vessels that grow into the cornea, the cloudiness of the cornea, and you can get cataract formation. So even escalating conjunctivitis to more severe cases of inflammation, these are the cicatrizing conjunctivitis examples. So this cicatrizing refers to scarring. So you have chronic inflammation that leads to scarring, and you can see how severe it can be on the picture. On that right, the whole surface of the eye, the cornea is all clouded over by scar tissue, and it's starting to look more like the skin of the eyelids. So we want to catch it, obviously, before it gets to that end stage. Examples of things that can cause scarring of the conjunctiva could be infections, adenovirus, chlamydia, Corynebacteria, diphtheria. It can be systemic conditions like the atopic keratoconjunctivitis. Stevens-Johnson, which we'll touch on in a little bit, is just like a reaction to either infections or medication. So it's a severe reaction to those medications. Autoimmune conditions listed there: lichen planus, lupus, mucous membrane pemphigoid, sarcoidosis, scleroderma. And then trauma or medications, medicamentosa, neoplasia, cancers can cause scarring, rosacea, inflammation of the eyelids and surrounding areas, radiation exposure, trauma, all can cause scarring. So one example of Stevens-Johnson, and I mentioned this because it's a medical emergency. This is fever, arthralgias or pain in the joints, bones, malaise, upper or lower respiratory infections suddenly develop, and then you have an inflammatory reaction where you have vesicles or bullae that form little blisters that involve the skin and at least two mucous membranes. And one of those mucous membranes tends to be the conjunctiva. It also affects the mouth and the throat. So you can have trouble with breathing, with swallowing. And so this can cause sloughing of the surface of the skin on the cornea and the conjunctiva, and that when it heals, can heal with scarring. So it's critical that we address this early. So causes, drugs, sulfonamides, especially antibiotics, sulfa antibiotics, anticonvulsants, non-steroidal antibiotics, or non-steroidal anti-inflammatory drugs rather. Allopurinol is used in like gout. Infectious causes, mycoplasma pneumonia, herpes simplex, adenovirus, streptococcal bacteria. So the treatment, as I mentioned, it's urgent need to get these patients to an intensive care center, treated like burn patients. The offending agents must be immediately discontinued. Systemic therapy is supportive, so to make sure that the surface is well taken care of, whether it's the surface of the eye or the skin, to prevent secondary infections and to prevent dehydration. Systemic treatments with steroids or immunosuppressive medications or immunomodulatory treatments, intravenous immunoglobulins are controversial when it's used on a case-by-case basis. Treatments of immunomodulatory, with immunomodulatory treatments, a whole list of different agents that are used and how they work. We won't go into too much in the way of detail, but this is like a common thread in all of this management of immune-related conditions or inflammation. When needed on a chronic basis to suppress the immune system, these medications are used. So going into the cornea, so this is an example of a 45-year-old gentleman with left eye tearing, irritation, redness for 3 weeks, no improvement with antibiotic drops. This is an example of an immune reaction or delayed hypersensitivity reaction to bacteria that live on the eyelids. So this isn't an infection, more an inflammation to the bacteria. So you have an immune reaction because it's right next to the limbus where all the blood vessels are. So normally there's no blood vessels in the cornea, but because it's near the limbus, you have an immune reaction to that. So the treatment is with steroids, and we'll sometimes use antibiotics just to reduce the number of bacteria that are on the eyelids. So marginal keratitis. Similarly, you can have, like in this patient, a 12-year-old who's presenting with irritation, foreign body sensation, a history of like chronic allergic conjunctivitis and blepharoconjunctivitis, which means just inflammation of the eyelids and the conjunctiva. This is similar to that marginal keratitis, but in this picture, it's chronic with blood vessels that have grown onto the cornea. This is flictennular conjunctivitis from blistering. So you have these nodules with blood vessels, with very angry blood vessels or very red blood vessels. It can become necrotic, ulcerate. So again, similar process, just a hypersensitivity reaction. Some people just react more to the bacteria that live on their eyelids. In the developing world, seen more with tuberculosis. In developed world, more with staph bacteria. So clean the eyelids, use steroids, use antibiotics. That's a treatment. And you can see here how you can calm all that aggressive inflammation down with that treatment. So 72-year-old patient, rheumatoid arthritis, left eye redness, pain, tearing, light sensitivity, decreased vision. You can see some ulceration there on the top of the cornea. It's thinner in that spot. You can see with the fluorescein staining how it looks like an area that is melting. This is peripheral ulcerative keratitis, crescent-shaped. You have an area with missing the surface layer of skin and ulceration. This is an immune reaction with abnormal white blood cells or T cells and antibodies that are deposited in the cornea. So it's reacting to the cornea as if it's something foreign, and it's melting the cornea. You can have also inflammation of the sclera, and you can have inflammation in the eye as well. So lots of conditions that can cause this. I won't go into all of it, but big categories: autoimmune conditions listed there, like rheumatoid arthritis, lupus, Sjogren's, autoimmune conditions where you have graft versus host, like in patients who have leukemia, who've had bone marrow transplants, that bone marrow, the cells can react to the patient who's received the bone marrow and attack what's normal tissue, but it thinks it's foreign. Infections, bacterial infections, viral infections, protozoal infection can all cause this ulcerative keratitis. Trauma, exposure, severe dryness can cause it, and some of the other conditions like the Stevens-Johnson or rosacea. So anything associated with inflammation around the eye can also contribute to this. Treatment, lubrication, but ultimately what you need is to suppress the immune system. You need systemic suppression with the steroids in the short term and immunomodulatory agents that we showed before in the long term. And you can, if it's real thin, you can use patch grafts to address those areas of thinning. You can strengthen those areas that are weak by putting tissue and filling up those areas that are ulcerated. And 54-year-old male, severe eye pain, watering, light sensitivity, again, ulceration you can see here. In this condition, it's Morin's ulcer. In this, we don't really know what's causing it, but it's similar appearance, but without underlying condition like rheumatoid arthritis. But treatment is similar. Again, suppress the immune system. Topical is usually not adequate. Systemic immunosuppression is what's needed. The sclera, moving to the white part of the eye, you can have inflammation that is on the layer above the sclera or episclera. You can have diffuse inflammation of the sclera or diffuse anterior scleritis, or you can have nodules that form, nodular scleritis. And severe enough, you can have thinning of the sclera and melting of the sclera. Again, the causes are similar to what we saw before, autoimmune conditions, and treatment is going to be similar. Again, steroids for the short term and then immunomodulatory treatments listed here for long term. So with that, I'll turn it over to Dr. Errera.
Thank you, Dr. Mammen. Thank you very much. Great talk. So we are still in the anterior segment of the eye with uveitis, with inflammation of the eye here. We see that there, on the right top, there is an inflammation with a lot of inflammatory cells behind the cornea, top right, and bottom right as well. And that means that the inflammation can affect the front of the eye, but it can affect the front of the eye here, but the vitreous, the intermediate part of the eye, it's intermediate uveitis, and the back of the eye, choroid and retina, and optic nerve. So we use a multidisciplinary approach to provide patient-centered care and may lead to faster, more streamlined communication between departments, potentially reducing the time to diagnosis and treatment. And this is important when addressing ophthalmic condition, particularly in the case of ocular findings, with which patients are likely to have an underlying disease. And because uveitis is associated with a systemic disease in 30% of cases, another 30% is caused by an infection agent, and in the remaining 40% of cases, the condition is idiopathic. That means that we can't find any cause for the eye inflammation. We think they might be autoimmune. So we use collaborations at the Vision Institute. We ask the help of our colleagues from rheumatology, pulmonology, infectious disease, dermatology, etc., etc. We use a lot of imaging for diagnosis and treatment. The Campbell lab is very useful, and research, imaging and immunology are the colleagues I'm working with. So why collaborations with the rheumatology combined clinic, with the Sjogren clinic from rheumatology, with the sarcoidosis pulmonologist, with neurology and infectious diseases? Because if we see patients, for instance, in the rheumatology combined clinic, it's a clinic where I see patients with Dr. Koka from rheumatology at the Vision Institute. We know that more patients are diagnosed with a cause for the uveitis. We know that more patients will be able to transition to steroid-sparing therapy if needed. That means that patients won't stay on steroids tablets or IV for too long. And we know that steroids, for instance, have many side effects. It can give diabetes to patients. It can put on weight, have mood changes. So we're able for those patients who need a systemic treatment to move to immunosuppressive treatment quicker. We have this the Sjogren Center that is run by Dr. Rachel Gordon, and she works in collaboration with the Cornea department, Dr. Mammen, Dr. Mukhtar, Dr. Dhaliwal, and they are specialists of dry eye disease related to this inflammatory disease, Sjogren. We're going to start a combined clinic uveitis and sarcoidosis with not only pulmonologists, but all the physicians who have a special interest for sarcoidosis. We know it can affect the skin, the heart. So at the moment, we have a multidisciplinary conference when we can talk about complex patients. So for instance, practically, how does it work? We have a patient in the left eye. We see that there are many lesions on the retina, and there are like scars, and then it can affect the vision. And then we refer the patient if we find that on the CT of the chest, there are some inflammation. There can be as well lesion on the skin. We call them erythema nodosum, and they can be related to sarcoidosis. So we need pulmonologists, dermatologists in that case. Other disease are more rheumatology related, like uveitis and inflammation of the front of the eye that you see here, with a lot of attachment of the iris to the lens, and it can really affect the vision. And we know that we call them anterior uveitis because they are from the front of the eye. They are associated with many etiologies. More common is seropositivity for human leukocyte antigen B27 that account for up to 50% of non-idiopathic anterior uveitis. What is HLA is a protein that helps the immune system identify which cells are part of the body and which cells are not. And these anterior uveitis related to HLA-B27 can be isolated or associated with systemic inflammatory manifestations. So some rheumatologic disease like ankylosing spondyloarthritis or psoriatic arthritis, and some gastrointestinal disease, inflammatory bowel disease. So when we find this anterior uveitis, we are prone to collaborate with our colleagues from rheumatology and GI. The uveitis can not only be autoimmune or inflammatory, it can be infectious. And this is a case, it's a dramatic inflammation of a recent patient we saw at Children's Hospital with bilateral inflammation of both eyes, both retina, likely related to cytomegalovirus retinitis. And how do we do the diagnosis and how we treat as soon as possible this patient? We collaborate. We have Dr. Ken Nishaz, chief of the Children's Hospital Ophthalmology Department. We have Dr. Pilblatt, Dr. Green from Infectious Disease Department. And then what we do, we perform as soon as possible a biopsy, aqueous humor sample, and the OR when it's a child to have it done under sedation. We have different options, as you can see on the right. We can take sample from the front of the eye or from the vitreous, from the back of the eye. And just running a video of how particularly clinically it looks like in the OR to do a biopsy of the vitreous using a microscope and doing it under sterile conditions. On the left, you see that we can take a sample through the syringe on the left. So we use those samples not only to treat patients, finding what is the germs, the bacteria, the virus, and finding the best treatment. We do also research. And when there is enough volume from those samples, we send part of it to the lab, and then we keep some of it if the patient agrees to be part of the research, and we send it to Dr. Anthony St-Leger's lab in immunology at the University of Pittsburgh, and he creates aqueous humor, so aqueous fluid from inside the eye, the bank, for cytokine analysis. And the cytokines are important in immunology because they are the proteins that act as chemical messengers in the immune system, signaling cells to fight threats and other functions. So we use this research to try to better understand the immune mechanisms of uveitis, because I told you that in 40% of cases we don't know the cause. And so if we don't know the cause, it's more complex to treat. We do also research in imaging, and we collaborate with Dr. Ethan Rossi's lab. Dr. Ethan Rossi, PhD, has published recently with the uveitis clinic here at the Vision Institute a paper in a medical journal about finding immune cells in the living human eye. And he used adaptive optics, which is a device to image the retina and to look at very, very small cells, vessels, so we can magnify everything. So how it looks like, you have different types of adaptive optics devices, and the patient put his or her chin on the bar, and we start imaging this patient. It's just pictures. And what we find is a figure from the recent paper, that in healthy patients without uveitis, we can see cells in the retina. And those cells are the cells from the microglia. You see it's a very high resolution, because on the right, you see the square where we are in the retina. So we are able to magnify the vessels. We can even see the retina cells individually. And the microglia, that the cells that we see with the arrow, they are immune cells that are in the central nervous system, and they are working to eliminate the microbes and to help repair the injuries. And usually we don't see them with the routine imaging system that we use for the retina. So it was the first time they were found out. And here they are magnified, so we see their shape better. We use this adaptive optics system to image our patient with uveitis. For instance, in cases of ocular syphilis, which is a sexually transmitted infection that can affect the retina and the optic nerve. On the right, you have a fluorescein angiography. It's a routine test that we use in the clinic to try to detect better the inflammation or the infection. And then we inject the dye in IV, intravenous, through one of the veins of the arm, and then we can take those picture. We knew it's an ocular syphilis because we do a blood test. We see the infection on the palm of the hand of the patients, and then we refer to infectious disease to have a final diagnosis of syphilis and to treat the patient, because it can lead to blindness. So infectious disease specialists were working with mainly Dr. Brandon Smith and Dr. Karen Meyer from UPMC. And then when we image this patient with syphilis, for instance, we saw that there are many more cells than the microglia cells that we were seeing in healthy patients, and we see those cells moving in the retina. We think that, and they are important for our immune system to try to fight those infections. And so we are going to pursue the study on those imaging research. So thank you very much.
Okay, thank you. We do have some questions coming in, but I want to start with a couple questions that I have. Over the last couple of years, I had some outpatient foot surgery. Both times what I thought was bleeding in my eyes and a rash all over my face, I later found out that it was conjunctivitis from the adhesive. You know, how often does something like that happen? Is it something that surgical teams talk about with patients afterwards? I'd love any insight that you have.
So yeah, happy to address that question. So it's not very common. And so I find that it's not something that is routinely discussed, but certainly, you know, we know that patients have allergic reactions to adhesives.
Mm-hmm.
And we certainly review allergies with patients prior to taking them to the operating room or doing procedures on them. Sometimes we don't find out. Sometimes it's a cumulative exposure to some chemicals that you can have like a delayed reaction. You might have had no issues in the past, but then, you know, this time you're exposed to the same thing, delayed hypersensitivity reaction to that. So even though, you know, we may not know it going in, certainly if there is a concern that you have, that's a good thing to discuss with your provider, and stop what you think might be the offending agent and see how, you know, your body reacts to it. You know, ultimately, you as a patient know your body better than anyone else. And so if you have a concern about something that may be adversely affecting your body, it's important to take the necessary steps that you think are right, but also make sure that your provider is aware that, you know, you have this concern and that this is what you've done.
Thank you. It was a learning lesson for me. So, and I've worked for Eye and Ear for 9 years. So I'm thinking a lot of people probably wouldn't know what it was. So thank you. So we've got some questions. Is there potential for immunotherapy drugs to help with these infections?
I'm unclear as to specifically what infections are being referred to, but you know, one of the things that we see with certain infections is, so certain infection can trigger immune reactions. And you know, I'll defer to Dr. Errera's expertise in this area, but certainly when you have an immune reaction that's triggered, especially something that's chronic, there are certain immunomodulatory treatments that are utilized to suppress that triggered immune reaction. But ultimately, you have to treat the infection. You know, certainly, so you have to treat the infection first and then address the inflammation. Sometimes you do it in parallel to treat the infection. Sometimes you have to make sure that infection is cleared before you can address the inflammation that goes associated with it.
I agree with you. I fully agree with you, Dr. Mammen. And there are some infections that you said trigger some inflammation. We see Lyme disease, for instance, which is very prevalent in Pennsylvania. Lyme disease can trigger retinal vasculitis, chronic retinal vasculitis. So usually we have the infectious disease. I refer to infectious disease. I stop doxycycline, but I refer to infectious disease because most of the time they add another antibiotics. And then they check if there is no inflammation of the CNS, central nervous system as well. And then even if the treatment has been efficient to kill Lyme forever from the body, you can still this inflammation that's still there. And so we use sometimes mycophenolate, Cercet treatment on long term once we are sure that the infection is no longer active. Same thing for tuberculosis. It can, even years after, it can trigger some uveitis, in which case sometimes when we are sure that tuberculosis have been properly treated, and is sometimes 9 to 12 months of treatment, we can use immunosuppressive treatment. But if a patient had cytomegalovirus, herpes virus, toxoplasmosis, that's an infection that never been cured. It will stay dormant after the treatment in the body. Herpes can flare again. zoster can flare again. We know because it can give encephalitis first in newborns and then flare in the eye years later. And so if we use immunotherapy drugs, the virus will flare again, so we can't use it. So we use other tips. We use injection of steroids, but it's not recommended to use immunomodulatory treatment in those patients.
Thank you. How common is ocular inflammation? What percentage of the population would you say will experience it?
So as we've, shown, ocular inflammation has many manifestations. So everyone gets ocular inflammation to some degree, whether it's a mild case of blepharitis or a severe case of retinitis or scleritis. So it depends on which specific manifestation we're talking about. The milder cases, like we said, everyone gets it to at some point or another. The more severe ones are much less common. The scleritis, the peripheral ulcerative keratitis, the uveitis, the retinitis tend to be a lot less common. And it depends on what the underlying etiology is. It often goes along with systemic conditions, but certain cases that we don't really find a reason for the inflammation. Those are even less common. Probably, about 50% of the time we for something like scleritis, we may find a cause, whereas the other 50% we don't really know why you have inflammation. We just have to treat the inflammation.
Gotcha. Thank you. This is a great one. Is it dangerous to swim in open water with your eyes open?
That's a good question. I would say that, yeah, I mean, we don't know what's in the water,
Right.
especially, these days, lots of pollutants get into the streams and rivers that, we might be swimming in. So I think the prudent decision would be to wear eye protection, goggles that keep the water away from the eyes. So definitely better to be safe than sorry.
Okay. What kinds of ocular inflammation might be long-term or chronic?
Dr. Errera, you want to?
Yeah, so can be acute or chronic, correct? What time can be acute or chronic? So just to answer about, I don't know if the previous question was about the incidence or how frequent is inflammation, but for uveitis, we know that in the population of United States in 2012, there were 133 patients per 100,000 inhabitants with uveitis. 133 per 100,000 inhabitants. So it's just to give an idea. It's quite a rare disease, but it happens. And any type of uveitis can be acute. So we can have one episode, especially if it's an infection and you treat the infection properly. But even if it's not an infection, even an autoimmune, for instance, it can get chronic. It's difficult to tell the proportion and to that all the time the patient asks, what is the chance that the inflammation of the eye start to get chronic or relapses over time? Or no one knows, actually. We have nothing to predict. So most of the time, if we see a uveitis, the patient will have one episode most of the time, but then it can get chronic or it can relapses. So it's important, and we have no way to predict when we see the patient for the first time what will happen. If it's an infection and we treat it properly, most of the time never happen again. But like we said, in Lyme, we can get chronic disease. In tuberculosis, we can get chronic disease. And if patients have herpes, it can relapse, like when they have cold sores. It can relapse if they have flu, vaccine, if they are tired, or for no reason.
Thank you. We have a question that has already been answered, but it's an awesome one, so we're going to ask it. What do you use to fill up ulcerated areas in the eye?
So we have a few options as far as tissues. We can't regenerate the tissue. So we cannot, if there's an ulceration of the cornea, for example, with peripheral ulcerative keratitis, you can't stimulate the cornea to make more corneal tissue. So we have to use, you can either use cornea, so you can get that from an eye bank. This is from cadaveric tissue that's either fresh or processed corneal tissue. You can use membranes, like amniotic membranes of different thicknesses. So this is what surrounds babies in utero. Really good for healing, has good anti-inflammatory properties. It promotes growth of those layers, like the epithelium that overlies it. So it helps to heal the eye. So we might use multiple layers of these membranes. Some of the thicker membranes, we don't have to layer as much. So you can use that for the ulceration of the cornea or the sclera. You can also use sclera. So this is cadaveric sclera that's been processed to help reinforce areas of scleral thinning. You can take, so sometimes you can take, depending on the cause, if you have an area of ulceration or if you're missing some tissue, like the conjunctiva, and you need it to help heal the surface, you might take it, say, from the other eye. But usually that's in cases where you don't have systemic involvement, like that affects both eyes. And you don't want to put the one eye at risk. So usually we're getting tissue from that's either processed or cadaveric tissue. We don't want to stimulate immune reaction to foreign tissue, so we try to use tissue that is less likely to cause those type of problems.
Thank you. Okay, next question. How long does it typically take for inflammation to resolve once treatment starts? What is the average length of time?
So I can answer this one, that one. Usually when we start, if it's an inflammation of the front of the eye, an anterior uveitis, it will be quicker than an inflammation of the back of the eye or from the front and the back, because all the eye can be inflamed. And we will use mainly steroid drops, but usually at least 1 month of drops. We taper down the steroid drops slowly. 1 month of drops. And while the patient will be on drops, vision can still be a little bit blurry. So it takes usually 1 month for the front of the eye. If it's the back of the eye and we need to use oral steroids and immunosuppressive treatment, usually it takes 2 months. It can be longer. Sometimes we have to, one immunosuppressive treatment is not working well enough. We have to switch for another one. It might take another month for this new medication to be fully efficient. So usually second one works. If it doesn't work, we have stronger one, biotherapy. We call them biotherapy. So, and then it can take 3 months, but usually anterior uveitis 1 month, posterior uveitis or panuveitis 2 months.
Okay, thank you. How often is there a risk of blindness from ocular inflammation?
So I can start. I mean, it depends. Ocular inflammation, like we said, is such a broad category. It depends on how severe a condition we're talking about. So certainly milder cases of ocular inflammation, less likely to cause blindness, but the more severe conditions that we demonstrated certainly can quickly progress to blindness if not treated urgently. So, and not only that, some of these conditions, because they are associated with systemic conditions, not only can they cause blindness, they can also lead to death. So, these conditions like peripheral ulcerative keratitis or scleritis or uveitis, even in some cases, they can be associated with systemic conditions that need to be addressed as soon as possible.
Thank you. Are some people more susceptible to infections?
I would say the general answer is yes. So
Mm-hmm.
there are certainly some genetic conditions like atopy where it's a dysregulation or the immune system's, which is normally finely tuned. The immune system just is not as finely tuned as it should be. So there's a delayed or a abnormal, I would say, an abnormal reaction to viruses, to suppression of viruses, for example, in atopic diseases. So these patients may be more prone to viral infections like herpes simplex.
Mm-hmm.
They may have more severe manifestations of those kind of infections. So certainly there's a genetic predisposition in certain conditions that can cause infections to be more severe.
And I can add, in my practice, when I see uveitis, mainly I see rare uveitis and infectious uveitis related to patient and immunosuppressed. When they just had a transplant, kidney transplant, liver transplant, they are on they are already immune system is already down, and then they are on immunosuppressive treatment to prevent a graft rejection, and then they are more sensitive to infection, even infection that usually, like cytomegalovirus, we have cytomegalovirus, 90% of the population has it dormant and it's not dangerous. And then if you're immunosuppressed, it can affect the eye. Or the same for toxoplasmosis, it can affect the brain if you're immunosuppressed. It's a parasite that usually your immune system keep dormant. And we have patients as well who have a cancer, lymphoma, leukemia, or other types of cancer that are immunosuppressed. And those are more sensitive to infection and uveitis. Even the chemotherapies that they have sometimes can induces a uveitis. So, and HIV patients with HIV, they are more sensitive to get uveitis and infections.
Thank you. Do some kinds of inflammation not respond to traditional treatments? Are there newer innovative treatments on the horizon?
Yes.
And
Innovative therapies, yes, definitely. Sorry. We still don't know. That's why there are so much research in uveitis. That's why we are doing the bank for aqueous humor, aqueous fluid. It's not. It would be better to have the bank for vitreous fluid, but we don't do major surgery to remove the fluid unless a patient has a risk to get blind. So it's easier to get the anterior chamber fluid because it's less risky. And then we try to understand with this research in immunology to try to understand the mechanism of the inflammation, just to try to find the best immunosuppressive treatment that target the inflammation. There are so many pathways in the inflammations. For each patient, sometimes they have a disease that looks exactly like the other, like birdshot keratopathy, so posterior uveitis, and all the patients look the same, but then we don't know why some immunosuppressive treatment work for some and other work for others. So that's why we work with rheumatology. We start one and then we see if it works. But sometimes it takes 1 or 2 months to be efficient. That's why we use the steroids first to stop the inflammation. And then we try another immunosuppressive treatment that works for the patient with the same disease, but not with the other one. So we don't understand yet why some treatment works for some patient and not for other. But we have many at the moment. We have clinical trials when we test new immunosuppressive treatment for uveitis, treatment that have been proven efficient in rheumatology disease sometimes. There are new treatment. It can be IV, can be subcutaneous injection, can be tablets, can be injection into the eye. So there are many clinical trials at the moment at the Vision Institute and elsewhere. And we have researchers as well that are looking for new treatment for this disease.
We're making you use your PharmD today to answer. So there are 2 questions here at the end, but I'm going to wrap them up together. So when should someone see a doctor, and how does the average person tell if they have ocular inflammation?
when should someone see a doctor? I mean, certainly if there are any concerns you have with your vision or how the eye looks or feels, there's no harm in getting it looked at, right? So the key is to address it sooner rather than later. And, you know, we say once a year is standard for just a routine eye exam. Certainly if there is something that just doesn't feel right, you're not seeing like you should, you know, you don't want to sit on it. And we want to make sure that you have someone take a look at it as soon as possible.
Good.
That's why we have the emergency acute care clinic now. It's at the Vision Institute, and it's open every day from 8 a.m. to 8 p.m. And there are eye doctors, even without any appointment, it's a walk-in clinic. Because we see patients, they wait to think that it will get better by itself. They don't wait when it's painful, but uveitis cannot be painful sometimes, especially in children. And then it's better just to go, even if it's just pink eye. We like better to see a pink eye and treat the pink eye than missing a uveitis that it's a blinding condition, because in United States, 10% of legal blindness is linked to uveitis in patients younger than 65-year-old. Older than 65-year-old, you have age macular degeneration, you have glaucoma, you have other causes of blindness. But in patients younger than 65-year-old, it's 10% of legal blindness. And most of the time is because the patient have waited too long before seeing an eye doctor.
So if you're in Pittsburgh, come to our first floor Urgent Clinic. It's there. It's not a long wait when you get in there. I think the average time is start to finish less than 40 minutes. So it's better safe than sorry. So that is it for today. Thank you both so very much. I think the big message is go to the doctor if you think you have something wrong, if your eyes are itchy. We will be back in 2 weeks with another edition of the Sight and Sound Bites webinar. Thank you, everybody.